Good evening, and thank you all for joining us today. On behalf of Nari Division of Jagsonpal Pharma, we welcome you all to the Journal Club today, up to date with updates organized by the Haryana chapter of ISAR. Today's article is on Diminished Ovarian Reserve. So we present to you Cystilia M. Cystilia M contains 1.1 gram of myoinositol formulated in the ideal ratio of 40:1 with D-chiroinositol to restore ovulation and reproductive health in women. Lycoredem tablets of natural lycopene fortified with N-acetylcysteine enriched with CoQ10 and L-carnitine for added advantage to win the race. Lycored M contains two proprietary complexes, natural lycopene as lycobeads from Israel and L-carnitine and L-tartric acid in ratio of 2:1 to give highest available L-carnitine as Carnipure, which is sourced from Switzerland. A warm and hearty welcome to all the esteemed faculty and attendees. Please note this webinar is streaming live on Facebook. You can share the link with your friends. The link has been shared in the chat box. To refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. We have with us Dr. Jyoti Malik, Chairperson, Haryana Chapter of ISAR, and Director Roots IVF at JJ Institute of Medical Services, Bahadurgarh. Ma'am, please kindly initiate the program.
Thank you so much. Thank you, Jagsonpal. Thank you, Dr. Deepika. And we are always very, very thankful to you for giving us the platforms so that we can share our knowledges and we can remain updated with the updates. So this is the episode 11 of Up to Date with Updates. And with my team of ISAR Haryana, with Dr. Meenu Handa as the secretary, Dr. Manju Dagar as clinical secretary, and Dr. Lakshmi as the treasurer. We welcome you on this platform, and we have the National ISAR always there for our support, for our guidance, and always a big thanks to Dr. Amit Patki sir, who's the medical director, Fertility Associates Mumbai, and also he is a consultant Khar Induja Surya and Khar Mumbai. So sir is our national president, and with his continuous guidance and support, we are also navigating through these years along with you, gaining lots of confidence, knowledge, and growing together, spreading our wings, I think. Thank you so much, sir. Then we have also always Dr. Asha Bakshi, the Secretary General of National ISA. We always she a very pleasing personality and always happy to help. And ma'am has been the vice president of West Zone Foxy. She has been the joint secretary of ISAR in 21, and she is the founder chairperson. And many thanks to the secretary general, Dr. Asha ma'am, for always being there for our support. Then we have the think tanks of ISAR. We have Dr. Nandita ma'am, who was the immediate past president. Then our president-elect, Dr. Sunita Tendulwadkar, our vice president, Dr. Madhuri Patil, and Dr. Sujata Kar, and the chairperson for embryology, Dr. Charudat, the vice chairman for embryology, Dr. Keshav. So with our think tanks always there with us, for our guidance and support, today we bring to you this episode where we have our presenter, Dr. Pooja Bhayana. On a very short notice, Dr. Pooja has prepared this, though we had, so today she would be presenting on a topic which is very important, diminished ovarian reserve. And these days, I don't know why, but in the OPD, within 2-3 days, one of the patient comes, a young patient coming with a diminished reserve, which really makes us think why it is happening and what do we do there. So so can we have the CVs of our expert? And today we have our expert, Dr. Nisha Bhatnagar. Dr. Nisha is a good friend, great person, medical director, Aveya Fertility and IVF New Delhi, and also a medical director at the Infinite Egg Freezing Center, New Delhi. So, she is also a faculty at the iCreate and also the head infertility committee of the DGF West. So she has her area of specialization is a natural cycle IVF with minimal stimulation and as poor ovarian reserve. So that is why I thought maybe we will have a great insight. Her comments would be very, very useful to us for today's presentation. And our presenter is Dr. Pooja Bhayana. She has also presented on this platform before. She is a fellow. She has done her fellowship in infertility from Ahmedabad. She is presently the consultant at Sonakshi IVF Hisar and was at Nova IVI Hisar in the past. So she has graduated from Chandigarh, also did her MD from Chandigarh and did her advanced embryology training at the BACC Bangalore and completed her endoscopy training, and post MD she is now dedicatedly working in the field of infertility. And I think today we would get a lot of insights on the poor ovarian reserve. I think the topic is therapeutic management. So this article is from the Fertility Sterility, which she would be discussing. And over to you, Dr. Pooja. Thank you.
Thank you, ma'am. Thank you so much. The topic is actually very vast, and the trials that have been clubbed in are too many. I've tried to see to it that I justify the topic.
It is indeed that is why we just kept only one presentation today. Otherwise, normally we keep two, but we thought because the topic is such, I thought let's discuss it in great detail, and Dr. Nisha would guide us. So you can start your screen share.
Right, ma'am.
Yeah. We can see it has started.
Okay. So the article is regarding therapeutic management in women with diminished ovarian reserve. It's basically a systematic review and meta-analysis of randomized controlled trials and was published in March 2025 in Fertility and Sterility. Diminished ovarian reserve, as we all know, it's actually a challenging situation for both the patients and the clinicians. And there are many therapeutic things that are available for the patients, but still we are not very much clear which works and which doesn't work. So this is all regarding the systematic review and meta-analysis. Now, diminished ovarian reserve can be seen in almost 2 to 29% of females whenever we stimulate a patient. Sometimes there are expected patients who actually show a diminished ovarian reserve, and sometimes unexpectedly the patient will be a hyporesponder. But yes, there are certain factors which can predispose a patient to diminished ovarian reserve, which could be the age of the patient, the most important marker, the smoking, environmental pollutants, and intrauterine nutrition, small for gestational age. Other factors, other surgeries done on the ovary, may be in the form of endometriosis surgery or prior any kind of surgery done in the pelvis related to ovary. These all could lead to diminished ovarian reserve in future. A patient who is having a cancer and being treated can also have a diminished ovarian reserve in future. So yes, there are certain risk factors for all these patients. And there are various biochemical tests to measure ovarian reserve. But the most important amongst them is AMH and antral follicle count that we now rely upon. All those patients who have diminished ovarian reserve, we all know that there is decreased response to stimulation in these patients with decreased number of oocytes retrieved, as well as these patients are actually somehow poor prognosis patients in the field of ART. The criteria that had been laid to classify these patients. In 2021, there came the Bologna criteria. In Bologna criteria, any of the two criteria needs to be fulfilled: advanced maternal age more than 40 years or any other factor for POR. could be form of endometriosis surgery as discussed earlier, or it could be a previous poor ovarian reserve when the patient was stimulated with the conventional stimulation protocol and you end up retrieving less than 3 oocytes in that patient, or an abnormal ovarian reserve test where the antral follicle count could be less than 5 to 7 follicles or AMH less than 0.5 to 1.1. So this was in 2011, long time back, which was laid down. And in this, they have said that any 2 episodes of poor ovarian reserve after maximal stimulation are sufficient to label a patient with poor ovarian reserve. Then there came the Poseidon criteria, which is actually which categorizes the patients of low prognosis into 2 categories: adequate ovarian reserve patients and poor ovarian reserve patients. When we are talking about diminished ovarian reserve, we are talking about group 3 and group 4 patients who are actually in this article when there is expected poor ovarian reserve, when there is AFC less than 5, AMH is less than 1.2. Now in this article, the criteria that was taken was AFC less than 5 and AMH less than 1.2. The research question of the article was to evaluate adjuvant treatments and protocols specifically applied to diminished ovarian reserve women identified using the antral follicle count or AMH thresholds proposed by the Poseidon group. The materials and methods used were the studies were selected which were having different ovarian stimulation protocols versus placebo, or non-intervention were compared in fertile women with diminished ovarian reserve undergoing ART. And various interventions that were assessed in this meta-analysis were the use of DHEA, testosterone, high versus low dose gonadotropin stimulation, delayed start protocol in GnRH antagonist protocol, use of letrozole, use of clomiphene citrate, growth hormone, luteal phase stimulation, dual triggering, dual stimulation, luteinizing hormone, estradiol pretreatment, and cortifolitropin alpha. So many things have been discussed in this article. The primary outcome that was looked into was the live birth rate, which is delivery beyond 22 weeks of gestational age or ongoing pregnancy if data on live birth was not available. The secondary outcomes that were assessed were the number of oocytes retrieved, number of M2 oocytes, clinical pregnancy rate, and miscarriage rate. So a systematic search was done using the Medline, Embase, and ISAR Web of Knowledge databases to identify relevant studies published up to June 2024. And the selection of studies included, for selection, they selected randomized controlled trials, including study population with diminished ovarian reserve, with basal levels of AMH or AFC consistent with the Poseidon criteria, AMH less than 1.2 or AFC less than 5. Case series, case reports, book chapters, congress abstracts, and Gray literature were not included in this. This was how the records were analyzed. So most of the records were actually, they were not fitting into eligibility criteria. So studies included were, for the qualitative synthesis were almost 35 studies, and studies that were included in the quantitative synthesis were 24. The relevant statistical analysis tests were done for these patients, and the p-values of less than 0.05 were considered statistically significant. Now coming to the results, which is the most important thing. First of all, coming to DHEA supplementation. DHEA has long back, I think since many years, it has been used to improve the ovarian reserve in patients. And there are many studies by Ballard and Gleischer which actually say that DHEA helps in improving the ovarian reserve, also in improving the oocyte number, also in improving the embryo quality, also decreasing abortion. So there are many studies. How does it help? DHEA is basically, it is leading to increase in androgen production in the body, which leads to increase in FSH receptors, which ultimately leads to increase in ovarian reserve. And there are various pathways which actually lead to more of oocytes and better embryo quality, depending upon the intermediate things which are in the form of insulin-like growth factors and other factors. Now, DHEA, as far as DHEA was concerned, 6 randomized controlled trials were analyzed in this, where pre-treatment was given with DHEA mostly for 3 months or 12 weeks before the control ovarian stimulation was started. And what was seen out of these 6 randomized controlled trials, that DHEA, it actually increases the number of oocytes. But in case you look at the number of mature eggs, you look at clinical pregnancy rate, live birth rate, or miscarriage rate, there is no difference. So although DHEA may lead to increase in number of oocytes, but clinically relevant things which are there, like like the live birth rate, they are actually not affected by using DHEA. This is the forest plot where the number of, this is regarding the DHEA itself, where the number of oocytes has been seen. There was a significant difference between the number of oocytes retrieved with DHEA. It was higher with DHEA, p-value 0.03. But if you look at the number of M2 oocytes, the p-value is not significant. Similarly, clinical pregnancy rate, not significant, p-value 0.89. The live birth rate or ongoing pregnancy rate was also not significant in the DHEA group. Miscarriage rate was not better. I would say the miscarriages were not less in the group which used to have DHEA prior to stimulation. The second thing that was studied was the testosterone supplementation. Testosterone, again, like in the previous slide I discussed, testosterone is actually important because it leads to increase in FSH receptors. It has been seen that low testosterone levels, they may be responsible for higher FSH doses and longer duration of ovarian stimulation in certain patients. And those patients who have less of testosterone may be less likely to achieve a pregnancy than in patients with higher baseline testosterone levels. So that is why there came the idea of testosterone supplementation. Mostly it is being used as transdermal testosterone gel. 5 randomized controlled trials had been analyzed regarding testosterone supplementation, where the testosterone supplementation was given. Different doses have been used. Different, I would say, duration of drug has been used. Doses have been ranging from almost 10, 12.5 to higher doses of around 25 milligram per day. And duration is 3 weeks, around 21 days to almost 6 weeks to 8 weeks therapy has been given in all these studies. Now, if you look at the results of the testosterone, if you look at the results, the number of oocytes, clinical pregnancy rate, and live birth rate were higher in the groups that had testosterone supplemented, whereas the mature eggs and miscarriage rate was not affected. In fact, testosterone is the only thing in this whole of meta-analysis which has been shown to improve the clinical pregnancy rates and live birth rates. None other thing has been shown to improve the live birth rates in patients who are supplemented with various things in poor ovarian reserve, in diminished ovarian reserve. This is the forest plot. Number of oocytes retrieved were higher, p-value 0.04 when patients were supplemented with testosterone. Number of M2 oocytes retrieved were not much significantly different. Clinical pregnancy rates were higher in patients who were supplemented with testosterone, p-value 0.010. And live birth and ongoing pregnancy rates were also higher, p-value 0.02. Miscarriage rates were not affected. Then the third intervention that was studied was high dose versus the low dose gonadotropins. High dose, when we say we look into 300 or 450 international units, in these studies 300 to 450 international units had been used. For the low dose protocols, they classified 150 international units. Although ASHRAE and all other committees have they have recommended that there is no point in going beyond 300 international units, but still I think I am also, and most of the people are also using 450 international in certain patients when we have a higher BMI patient. But yes, if you compare these two doses, what was the result? There were 3 randomized controlled trials that compared low versus high dose regimens. And in case you look at the number of oocytes were lower when you stimulated your patient with the lower dose, that is 150 units. But this practically was not of much importance because the clinical pregnancy rate, live birth rate, and miscarriage rate is not affected when you give your patient with the minimal stimulation protocol starting with 150 doses, or you start with the conventional stimulation protocol utilizing 300 or 450 units of your drug. So yes, low dose protocol can be used in these patients without affecting the live birth rate or clinical pregnancy rate. The oocytes retrieved were significantly higher with the higher dose. P-value was significantly, this was highly significant when there was a comparison between the low dose and the high dose group. But if you look at the clinical pregnancy rates, the p-values are not significant. P-value for clinical pregnancy rate is 0.86. For live birth or ongoing pregnancy rate, it's 0.87. So although you have better number of oocytes, but it doesn't translate into better pregnancy outcomes in the form of live birth rates with high doses. Then the fourth intervention was delayed start protocol. Delayed start protocol. Why delayed start protocol? Because as we all know, poor responders, sometimes you see the follicles which are actually discoherent. You don't have a coherent kind of cohort of follicles. So this is one reason where your patient may land up in poor response. So to stimulate, you can actually balance this cohort or synchronize this cohort. There came the idea of starting the delayed start protocol with initially giving GnRH antagonist for 7 days and then starting off with the GnRH antagonist protocol in the patients. 3 randomized control trials were analyzed for this. So the patients, they were initially given from day 2, 7 days of GnRH antagonist before starting the proper gonadotropins for controlled ovarian hyperstimulation. For this, the number of oocytes retrieved were higher with the delayed start protocol. So yes, the number of oocytes definitely were higher when you started the patient after 7 days of GnRH antagonist. The M2 oocytes were also significant, but clinical pregnancy rate again was not significantly different between the two groups. And the live birth and ongoing pregnancy rate was also not significantly different between the two groups. The miscarriage rate was also similar between the two groups. So delayed start protocol, you tend to have better number of oocytes, better number of M2 oocytes, but no difference between the clinical pregnancy rate, live birth rate, and miscarriage rate. Now, addition of letrozole. Adding letrozole is actually having an, this is an aromatase inhibitor, which leads to decrease in estrogen in the body. And because of this, the negative feedback of estrogen is gone and you have a higher stimulation. You have more of FSH release from the hypothalamus pituitary axis. And this letrozole has actually been used in stimulation protocols, especially in patients who are suffering from carcinomas. A large number of studies were analyzed for this. 4 randomized controlled trials were analyzed, which utilized letrozole along with the stimulation protocols. Studies were variable. Somewhere letrozole was given for initial 5 days and stimulation was started post 5 days of letrozole. In certain studies, letrozole was simultaneously started from day 2, 3 onwards, and 150 units or 300 units of your gonadotropin were given. So the studies are actually variable, but what was the outcome? That as far as the number of oocytes retrieved, mature eggs or clinical pregnancy rate or live birth rate or miscarriage rate was concerned, there was no significant difference. So the inference from this is, what I could get is that letrozole can be used in case you are having a patient with a diminished ovarian reserve, although ASHRAE is not recommending all these, I think. But letrozole can be used in case you want to cut the cost for your patient. Suppose I give letrozole initially for 5 days and then you start with the stimulation later on. Or you give letrozole and start with the low dose stimulation. In that case, you can cut the cost of injections for your patients. Clomiphene citrate again has been studied, and 3 randomized controlled trials were analyzed. But again, there was no significant difference in as far as the number of oocytes retrieved, mature eggs, clinical pregnancy rate, live birth rate, or miscarriage rate was there. Growth hormone is actually something which is, I think it has been used since long, almost 10 years. I've also been seeing growth hormone, and its supplementation is actually done in poor responders because it is seen that growth hormone stimulates estrogen production, and oocytes from follicles with high growth hormone levels, they may have better developmental potential. Now, for growth hormone, 2 randomized controlled trials were analyzed, although there are many other trials also, but they have mentioned only 2 randomized controlled trials, which were actually fitting into the criteria as far as this analysis is concerned. The one trial was by Cho et al., which showed significantly higher number of M2 oocytes retrieved, but there was no effect observed on clinical or ongoing pregnancy rates. Another trial was in 2019, Lee et al., where the oocytes collected, embryos transferred, clinical and ongoing pregnancy rate were significantly higher. So the results are actually not very much clear. We are still not very much clear how growth hormone helps or whether it helps or not. But yes, there are variable results where people have found benefit of giving growth hormone, where people have not found any benefit of growth hormone. Personally, I have been using growth hormone in my patients who are actually of diminished ovarian reserve. And luteal phase stimulation for poor responders. Initially, for all the patients, initially we used to have one stimulation, like follicular phase may start karo whenever the patient lands to you on 2nd or 3rd day. This was because we used to think that there is a single wave of folliculogenesis that happens during a single menstrual cycle. But then over the time, it is very much clear that there may be 2 waves or 3 waves ongoing, which can be tapped. So different waves can be tapped in a single menstrual cycle in the same patient. There came random stimulation protocol or the luteal phase stimulation. Luteal phase stimulation has also been used in poor responders. And in the luteal phase stimulation, the comparisons in these, the studies that were included in these meta-analysis were actually comparing the luteal phase stimulation along with conventional follicular stimulation. And it was seen that there was no difference in number of oocytes retrieved, M2 oocytes, and live birth rate in patients who were given either luteal phase stimulation or conventional start. Now, dual trigger is another modality. Dual trigger, you are triggering your patient with HCG as well as you are giving the GnRH analog. This is because these two have different mechanisms of actions, and there have been trials which have studied dual trigger approach. Dual trigger approach is in 2023. It was studied by Keskin et al. In a randomized controlled trial. And what they could find is that there is no difference in the number of oocytes retrieved and M2 oocytes when you are triggering your patient in when you are giving a dual trigger to your patient. So there is no difference with the dual trigger, but live birth rate, it's actually something which is opposite to my mind. Actually, this is something which is new for me. The live birth rate was better with HCG as compared to when the patients were triggered with both HCG and decapeptyl. Now the dual stimulation approach. Newer thing is dual stimulation. You're stimulating your patient twice in a single cycle, the follicular phase stimulation and then the luteal phase stimulation. This is because, this is again because of the multiple waves that are occurring in the same cycle, that you can stimulate your patient twice in the same cycle. Now, dual stimulation approach was studied in 2 consecutive rounds of the dual stimulation was studied with 2 consecutive rounds of stimulation in the follicular phase and the luteal phases. 2 randomized controlled trials were there, Massin et al. In 2023. So, as per this trial, the dual stimulation approach actually led to no significant difference in the number of eggs retrieved or the M2 oocytes or the cumulative live birth rate. But another trial by Carillo et al. In 2023, although it showed that the number of eggs retrieved with double stimulation, dual stimulation are higher with your dual stimulation approach, but number of M2 oocytes or cumulative live birth, there is no significant difference. But dual stimulation becomes important in poor responders because it leads to decrease in time to pregnancy. So yes, as far as a patient is concerned, stimulating the patient, wasting time for 2 cycles or 3 cycles is much more difficult and tiring for the patient. But when it is being stimulated in the same cycle, when the patient can have 2 times egg retrieval, so the time to pregnancy decreases in such patients. LH addition, LH since long has been used in certain categories of patients. And these are the ones where you actually need LH when the cycles are down regulated, when your patients are pre-treated with OC pills for a longer time. Age more than 35 to 40 years is definitely 2 categories where your patients are actually benefited from LH. Is your age is more than 35 to 40 years, when your patient is hypo-responding, or another category is hypo patients where LH is required. LH use in diminished ovarian reserve is still controversial, and various randomized controlled trials, out of their various randomized controlled trials, two randomized controlled trials were fitted into this meta-analysis, and it found that there was no significant difference in the oocyte retrieved or metaphase 2 oocyte or live birth rate when the patients were supplemented with luteinizing hormone. This was by Humadan et al. And Tosson et al. Showed that significantly higher number of oocytes were retrieved, but clinical pregnancy rate is still, it's not different when you're supplementing your LH in your diminished ovarian reserve. So LH hormone, we still are not very much clear how much it helps. Estradiol pre-treatment, again, to regulate the cohort, to synchronize the cohort, you can give estradiol to your patient, 2 milligram BD starting from day 21 of the cycle. And one of the randomized control trials was included in the study where estradiol pre-treatment was given to patients with diminished ovarian reserve. The number of oocytes retrieved mature eggs clinical pregnancy rates were comparable. There was no difference in the number of oocytes M2 and clinical pregnancy rates, whether the patient was given estradiol pre-treatment or she was directly started without estradiol pre-treatment when she was a diminished ovarian reserve patient. Corifoliatropin, it's long-acting gonadotropin, and corifoliatropin has been studied in certain trials. Fusey et al., he had a randomized control trial where he included the patients with antral follicle count of less than 5, AMH less than 1.1, where the patients had less than 3 oocytes retrieved in the previous cycle and age was more than 40 years. So the study group received corifoliatropin alpha supplementation using the antagonist or the agonist protocol, whereas in the control group, they followed antagonist protocol without corifoliatropin alpha supplementation. And it was seen that oocytes retrieved, mature metaphase, mature oocytes and ongoing pregnancy rates were higher in the study group. So this is how number of oocytes retrieved, number of M2, they were higher with the corifoliatropin alpha group. Ongoing pregnancies were also higher, but it is not of, I would say the numbers are not too large to comment that actually corifoliatropin helps or not. There was another trial where again corifoliatropin alpha was used, but it showed no significant difference in the oocytes retrieved, mature or M2, oocytes or clinical pregnancy rates. So just this was something which I could catch at the end, that in case you are using testosterone, as far as this meta-analysis is concerned, there is improvement in the live birth rate when you are using testosterone. Otherwise, none other intervention has actually led to improvement in the live birth rate or clinical pregnancy rate. As far as oocyte yield is concerned, testosterone, DHEA, and high-dose gonadotropins can help in improving the oocyte yield, whereas delayed start, letrozole, clomiphene, growth hormone, corifoliatropin alpha, luteal phase stimulation, dual stimulation, LH supplementation, sterile pre-treatment, these are actually showing no effect as far as per the randomized control, this meta-analysis is concerned. That's all. Thank you.
Yeah, thank you so much. Thank you. That was wonderful, Dr. Pooja. I think you've covered all the adjuvants that have been tried for diminished reserve. And now I would take comments and from Dr. Nisha. So what Dr. Nisha would like to add, and then we could what exactly maybe we are using. Actually, in your last slide, you have summarized what all is I mean, only I think the testosterone stands the test of time, I suppose.
Yes.
But over to Dr. Nisha first for your discussion.
Thank you, Dr. Jyoti. First of all, thank you so much for giving me this platform to share and discuss what is going on, the latest updates we are talking about. And this is a very good initiative. And I think Journal Club is something which we all should be doing. Secondly, I want to congratulate Dr. Pooja for covering this topic so well. I think she read the article and almost everything was beautifully covered and the summary was excellent. Now, this is all the trials they have done, but I'll tell you three things here. I do a lot of natural and minimal stimulation cycles. And the first most important thing I think we need to remember regarding infertility treatment is individualization. So whatever we said that, it is generalized trial, we might be using different things for different people, but we will have to analyze each patient as an individual. The first cycle is always the learning cycle. We'll have to see how things work for her. Maybe she gets pregnant in that first attempt, but if not, you should thoroughly analyze that cycle and then go for the next cycle, specifically in case of poor ovarian reserve. Secondly, you said that mild stimulation, everybody is saying that instead of using mild stimulation, high dose stimulation, we get the number of eggs is more, the M2 is more. And even there was an article which says that euploidy is not affected. But my favorite is mild stimulation, and specifically only Clomid cycles I do for poor ovarian reserve patients. And there are three things here which are very important. Number one is that
Even if in worst case scenario we need to cancel the cycle, the cost part is not much for the patient. Because in poor ovarianism, so many times it happens that we give a lot of medicine, injections, and then we might need to cancel for either no development or, one premature surge or something like that. So the cost part is very important. Second thing, when we are going to get one or two eggs only, after giving 40-50,000 worth of injection, isn't it worth trying that give Clomid only or give letrozole only and get that one or two egg? There is a higher chance of that egg giving you pregnancy because the patient is more comfortable, more satisfied, the cost part is not there, and the euploidy, again, the quality of egg is much better because we are not going to push the body to overperform. This is the second thing. And the third most important thing which we need to remember about the natural cycle is the natural cycle per transfer, the success rate is still higher than conventional IVF. The cumulative pregnancy rate we are talking about. You might take more than 2 cycles to get that one beautiful blastocyst, but the natural cycle per transfer, the success rate is high. The per pickup, I'm not talking about. You might not get that egg, you might not form the embryo, you might not, you might not even retrieve any egg also. But if you get that one egg and it forms a good blast, the per transfer success rate is much, much higher. So we all should be, first of all, deciding the protocol depending upon the patient. There might be a patient where you might need to give a little higher dose. There might be a patient which will respond to testosterone, as you said, but there might be a patient which might respond to estradiol pre-treatment. There might be a patient which will respond to dual stimulation. So you will have to keep your antennas high and, decide the protocol for your patient smartly. Finances play a vital role, and also I all of everything, I think counseling is the most important thing. Other than that, you have covered the topic very beautifully. Congratulations one more time, and thank you, Dr. Jyoti, for including me in this.
Yeah,
Thank you, sir.
thank you, Dr. Nisha, for your comments. And that is why I wanted to include you, because you are a pro natural cycle and a minimalist.
I am.
You have a minimalist approach, so you don't, and especially in poor responders where you cannot do anything. ज्यादा गोनेडोट्रोफिन्स देने के बाद भी हमारा वही दो दो एग को उतना ही थोड़ा गोनेडोट्रोफिन या क्लोमिफिन भी दोगे तो भी चलेगा. So
sometimes the patient wants to have a natural cycle, not IVF I'm talking about, and you give letrozole, you'll have 2 or 3 follicles. You see beautifully growing 3 follicles, and then you next cycle when the patient is planning for IVF, you give HMG again, there is same response. So definitely, Dr. Nisha's words are worth taking. That cost has to be taken care into whenever we stimulate our patient.
Also, so many times it happens that there is a desynchronization in the cycles. When the reserve is low, actually what happens is that patient is infertile because the egg is forming early and rupturing early and the endometrium is not ready. So what we do is that without doing anything, there might be other reasons of infertility. Always it's not about the egg. AMH is not a predictor of outcome of or success of IVF cycle. So we should not think about that low AMH. Poor ovarian responder is something different. Low AMH is something different. So we have to be clear about what we are planning to do. And even single egg can give you a pregnancy, where at the same point, even 10 might not give you the pregnancy.
Right.
So try to see what is the right approach for your patient.
Yeah.
Right.
And definitely age, when if it is a lower age, though low AMH, still the egg quality is good.
Might
So
be better.
we can have a better prognosis in such cases rather than Posidion 4, where the age also is lesser and the ORTs, the reserve tests, are also haywire.
Rightly
So
said.
I mean, besides the studies and the RCTs, what all practically you are using for your low ovarian reserve patient? Like I'm using growth hormone, I'm using testosterone gel and DHEAs, and so these are the 3 things. Then maybe adding letrozole with stimulation and dual trigger. These are the 4-5
Yeah,
things
we all
that
do dual trigger. We all do dual trigger, and I think it does increase the number of M2s. But
Yeah.
I think testosterone gel was something which I was very skeptical about. I have not used it a lot. I was using it in specific cases, but after going through Pooja's article and seeing her presentation, maybe that is one change which I'm going to do in my practice. Maybe I'll be a little more open about it. So thank you so much for that.
Thank you,
Okay.
ma'am.
And Dr. Pooja, what practically you are using in your patients? You said
I've been using, ma'am, testosterone gel. I've been using growth hormone and minimal stimulation with letrozole or clomiphene, like 5 days of CC 150. Sometimes I give, and then later on I start with the HMG. So this is how I've been doing. And
You can
sometimes, like,
continue
it's not very
throughout
much.
also. Dr. Pooja,
Sorry,
I'm sorry to interrupt, but you can continue Clomid throughout the cycle
of the
also.
cycle.
Even with HMG, when you are adding HMG, see one tip I'll give you here is that, see, there is an optimum level of FSH. Beyond that, if you try to push by giving high dose of gonadotrophins or something, you are not going to get response. That optimum level of FSH is somewhere around 18, 19, 17, 18. That is after giving gonadotrophin. So if the patient is already coming with a very high FSH, that is actually true poor ovarian reserve. The FSH levels are very high. At that point of time, if you try to push, you are not going to get neither you are not going to get more eggs, nor you are going to get better eggs. So in those cases, if suppose you give only clomiphene, you will get that two eggs. You will see later on that the FSH sometimes starts dropping. At that point of time, if you add HMG and continue Clomid, you will get beautiful 2 or 3 eggs, and then there are higher chances of pregnancy. So you can continue Clomid throughout cycle also. It not only stimulates, at some point of time, it acts as an oral antagonist also. So
Right,
it
ma'am.
doesn't let the surge happen.
Right, ma'am.
So then when you're continuing with that, do you add antagonist or you are not adding anything? You prefer
I am usually adding Dufeston as the antagonist. I do all oral medication only. My cycles are Clomid plus Dufeston, or letrozole plus Clomid, or Clomid plus Dufeston plus letrozole. So all oral tablets I'm playing with. I add antagonist very rarely. That is when, I see more than double the rise in LH. Then in the later part, when I see that my follicle is 16, 17 millimeter, and I want to give a day or more, or something else is there, then I add antagonist. Otherwise, I usually don't add antagonist.
okay. So Dufeston, when do you start, Dr. Nisha? I
I
mean,
start from the third or fourth day of stimulation
exactly your
throughout the
protocol
cycle.
is that you start clomiphene 50 mg or 100
100,
mg. How do
100.
un-
I continue Clomid
so
100 throughout the cycle, and then from the third or fourth day of stimulation, I add Dufeston. But then I check frequently. Not only the ultrasound, I do the LHE2 levels also if needed.
Ma'am, how frequently do you get these levels then? LH and E2?
No. I'm doing that only if, like, not frequently. I
Okay.
do ultrasounds frequently. So if I see that there is a sudden increase in the size, or if I have some doubt on the ultrasound, then I get the LHE2 levels done. And if my
Okay.
LH is increasing fast, and then I add antagonist. Otherwise, usually I don't add antagonist.
okay. So
Personally, I've not been doing any hormonal monitoring during my cycles, but one thing which I have recently started, I'm not sure what is right or not, but for those patients who are actually having ICSI indication for male factor infertility, where the female partner is also having very low reserve. In those patients, I've been nowadays doing oocyte freezing, stimulating the patient, going for oocyte freezing 2 or 3 cycles when you accumulate the oocytes, and then I plan for ICSI for those patients. 4 or 5 patients we have done like that, and I think it's something which is good for these patients when the oocyte quality is good in a young patient.
So I think that is what I would prefer to do, is do the pooling cycle, but do ICSI with each egg. It may a little bit increase the cost, but the only thing we don't even know how many epigenetic changes we are inducing by freezing the eggs and then thawing and then doing because they are coming with the embryo transfers also. So you are doing the right thing. Your approach is right, but maybe if the cost is not a problem, maybe you can do ICSI for whatever, even 2 eggs you got. ICSI those, freeze the embryos, then 2 more you can get. Somebody who's doing multiple cycles of pooling, maybe another 30,000-40,000 won't be a lot of a difference for them. So
right.
I also do this multiple cycles of pooling. I also do dual a lot. but I prefer to freeze embryos instead of eggs. So whenever I'm getting a egg, even single, I'm doing ICSI, and but I'm taking it to day 5. If it reaches a blast, then I freeze, then go to the next cycle, do the same thing, take a egg, freeze a embryo. I prefer not to freeze the eggs unless they are, indicated. But it may be something in my mind only. Because I feel that we are inducing those epigenetic changes, and we don't know what
Yes,
happens.
the things are still not very much clear.
Yeah.
We are doing
Yes.
certain things recently, and we are not very much clear what are going to be the outcomes in future of all these things.
Yes.
So
So
long studies.
one principle I follow is do anything which is medically indicated.
Right.
Don't try to try to keep it simple.
Ma'am, for embryo freezing, I am little bit skeptical. Skeptical why? Because I think अगर मेरे पास एक blast बन जाएगा तो I'll rather transfer that and
I
freeze it.
I agree with you. I agree with you, because that is also the same thing which I have in my mind, that if I am not doing a transfer, maybe the only thing why I'll tell you is that when I'm doing a pooling cycles, and these are the females who are coming later age, 38 and 39. So I counsel them well, and I have one blast, and we have this discussion whether we should go for transfer or pool. The only thing I have in my mind is that usually we try to have at least 2 children. So suppose if I transfer this blast and hopefully she gets pregnant, then the cycle is gone for 9 months, and then she will be, I try to keep myself positive that it will give me the
Right.
result. So then that I counsel her, that if you have, yeah, if you by that time, who knows what will happen to your reserve. So if you
Right.
have 2 blast or something, maybe you can transfer the second one 1.5, 2 years later. That's the approach. But I agree with you, if I have one blast, maybe transferring is the right option. That's it. Thank you. Thank you so much, Dr. Jyoti, and thank you so much, Dr.
Hello, that
Pooja. It
was a
was
wonderful
wonderful.
discussion we had. And though the participants always are very less in our these up to dates, but whoever are there are people who are genuinely interested. So though we keep circulating about these up to dates, but the participant, though Dr. Deepika also makes it a point to post to everybody. We don't get many people here on the platform, but definitely we have this always on the Facebook live, and also I've put in the group, so people who cannot who do not join now maybe can listen to us later and may get benefited. And this was a lovely discussion we had, a lovely presentation, Dr. Pooja, and
Very good.
good,
Wonderful.
very insights, Dr. Nisha. You first on, you give how much for how long?
10
Till
milligram, 10 milligram BD till I trigger.
till the trigger.
Yeah.
And okay. And cetrorelix or antag you add
I
only
avoid.
when
I
needed.
avoid.
When needed.
When needed, yes.
So we could learn your protocol today also.
Thank you. No problem.
So thank you so much. Thank you, Dr.
Thank you
Deepika.
so much.
Over to you, Dr. Deepika.
Knowledge share is never in loss. So
Yes.
it will always be useful one day to someone, maybe.
Yeah.
Thank you, all the experts present here. And also, I'd like to just highlight here that our recording on Facebook Live will remain on the Facebook. Jagsonpal Pharmaceuticals is the name of the Facebook page. And also on our YouTube channel, which is Jagsonpal Medical Insights. So all the recordings remain there. And till now, I was just checking the Facebook Live views have been 200 while the webinar was on.
Yeah.
So, yes,
Oh my
ma'am.
God.
Sometimes it happens that some people
Oh,
come
that's
and watch a little and go. So may have happened like that, but there have been 200, and as the time passes, recordings are seen and it continues till about 2000 also, and the Facebook, YouTube recordings also come up later on.
Yeah.
It will come up within 2-3 days, and then we see that 400 500 ऐसा कुछ करके recordings के views बढ़ते ही जाते हैं. So we
It is
should
not
yeah.
disheartening.
No,
Dr.
no.
Pooja, great.
So the speaker need not get disheartened because views तो बहुत आते हैं, ma'am.
You did a wonderful job. Congrats.
Thank you.
Thank
And
you.
especially on our
Right.
doctors are now knowing that Jagsonpal YouTube में बहुत होता है material. They, especially the PG students and all, they are referring to it a lot. So they come and visit our
Yeah.
channel a lot.
Thank you.
So here I would like to just thank
Great.
you all for the support that we are getting for Cystelia M. Again, I'd like to just highlight Cystelia M contains 1.1 gram of myoinositol in each tablet, which is formulated in the ideal ratio of 40:1 with D-chiro-inositol to restore ovulation and reproductive health in women. Also, we look forward to your support to Lycored M tablets for male infertility. These are natural lycopene tablets fortified with N-acetylcysteine, enriched with CoQ10 and L-carnitine, L-tartric acid in the ratio of 2:1. So we have lycopene as natural lycopene from Israel, which is lycobeads, and L-carnitine as carnipure, which is sourced from Switzerland. So thank you all so very much for joining in and sharing the knowledge. Thank you. And we hope
Thank
to
you,
see you
Jagsonpal,
again.
for giving me this opportunity. Thank you, Dr. Jyoti.
Thank
And wonderful job, Dr. Pooja.
Thank you, ma'am. Thank you so much, ma'am.
Thank you, Dr. Deepika, Jagsonpal, Dr. Pooja, and Dr. Nisha. Thank you.